Picture this scenario. You've been preparing for weeks for your mesothelioma surgery. Your surgeon has laid out the plan clearly, and you've had your scans, your biopsies, and all your pre-surgical consultations. You've told your family, you've prepared your home for recovery. You walk into the hospital knowing you've done everything right. Then you wake up from anesthesia and learn that the surgery did not go as planned, because once the surgeon opened your chest, they found more disease than expected, and the operation that was planned couldn't be completed. This is one of the most devastating pieces of news a mesothelioma patient and their family can receive. I want to talk about it today directly, honestly, and with compassion, because it happens, and patients and families deserve to understand why it happens, what it means in the moment, and most importantly, what it means for the road ahead. The short answer is that it doesn't mean the end of hope, and it doesn't mean the end of treatment. I'm Terri Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a doctor, and this is not medical advice. But today I want to address this difficult topic with the honesty and care it deserves, because I believe that being prepared for every possible outcome serves you better than being left unprepared when the unexpected happens. So let's start with acknowledging how challenging a disease mesothelioma is, and the fact that it is notoriously difficult to assess accurately on imaging. That's part of the reason it's so hard. CT scans, PET scans, and MRIs give surgeons the best possible preoperative picture of how extensively the disease has spread. But mesothelioma is a disease that grows in thin, diffuse layers along the pleural surface in ways that even the most sophisticated imaging technology doesn't always capture. It can track silently into fissures between the lobes of the lung. It can infiltrate the mediastinum, which is the central compartment of the chest. It can invade the chest wall or extend to the pericardium, which is the sac surrounding the heart, in ways that only become apparent once the surgeon's actually inside. Research has shown that in patients undergoing planned surgery for mesothelioma, a meaningful percentage, in some published series as many as 1 in 4, are found intraoperatively to have disease that is more extensive than expected or that is frankly unresectable. The most common reasons include tumor involvement of critical mediastinal structures like the aorta, esophagus, or the major blood vessels, invasion of the chest wall beyond what imaging suggested, or disease that has spread more broadly along the pleural surfaces than any scan could have shown. When a mesothelioma surgeon encounters these situations in the operating room, they have to make decisions in real time based on what they see, what they can safely do, and what will ultimately serve the patient's best interests. In some cases, a modified approach is still possible, a less extensive operation than originally planned, which removes the most accessible disease and relieves pressure on the lung, even if that means not achieving complete resection. Surgeons refer to this option as debulking or cytoreduction. And while it doesn't eliminate the cancer, it can meaningfully improve symptoms, particularly breathing difficulty caused by the tumor's bulk. It can also improve quality of life. In other cases, if proceeding with any meaningful surgery would put the patient at unacceptable risk without providing real benefit, the surgeon may make the tough decision to close the incision and stop. I want to say clearly that this is not a failure, and it is not giving up. It's a carefully considered decision made entirely in the patient's best interest, one that preserves the patient's strength and reserves for the treatments that can still help. Now, before I go on, I'm going to take a break here to ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or there's a topic you'd like to see addressed in a future video, send me a note in the comments section. And make sure you watch until the end, because I'm going to give you valuable information on where to find resources that will make a real difference for you. So, Waking up from surgery to learn that what was planned couldn't happen is an enormous emotional blow. And I don't want to move past that too quickly. It's okay for that to be devastating. It's okay to grieve the plan you had that didn't come true. Give yourself and your family that space. But when you're ready, I want to hear this as clearly as I can say it. Unresectable doesn't mean untreatable. The word unresectable only means that the tumor can't be safely removed through surgery. It doesn't mean that the disease can't be slowed or controlled. It doesn't mean that there are no options, and it doesn't mean that meaningful time and quality of life can't still be achieved. For patients whose mesothelioma is determined to be unresectable, whether that's found before surgery or discovered during it, systemic therapy is the primary treatment path going forward. The landscape of systemic therapy for mesothelioma has dramatically changed in recent years. 2 immunotherapy regimens are now FDA approved specifically for unresectable pleural mesothelioma. One is the combination of nivolumab and ipilimumab. Their brand names are Opdivo and Yervoy. That was approved in 2020 as the first new mesothelioma treatment in 16 years. Pembrolizumab, combined with chemotherapy, was approved in 2024. Both have shown meaningful survival benefits for patients who aren't surgical candidates, and both represent significant advances over what was available even 5 years ago. Standard chemotherapy with cisplatin or carboplatin and pemetrexed remains a foundational option as well. And for some patients, a strong response to systemic therapy can bring the disease to a point where surgery is reconsidered. This is a strategy called induction therapy, and researchers continue to refine it. Palliative procedures also remain valuable and important regardless of what happened in the operating room. If significant pleural effusion, that's the fluid buildup around the lung, is making breathing difficult and painful, procedures like thoracentesis to drain it or pleurodesis to prevent it from reaccumulating can provide genuine and meaningful relief, even when curative surgery isn't on the table. If you find yourself navigating this situation, please ask your oncologist directly about clinical trial options in addition to standard treatments, because patients with unresectable or partially resected mesothelioma are often good candidates for trials that offer access to newer therapies that aren't yet widely available. And please, don't face it alone. Mesothelioma.net exists to connect patients and families with the resources, specialists, and support they need at every stage of the disease. To review, sometimes mesothelioma surgery finds more disease than was expected. It happens because imaging has real limitations in capturing how this deadly disease spreads. When this occurs, the surgeon makes real-time decisions aimed at the patient's best outcome. It's important to remember that unresectable mesothelioma is not the same as being untreatable. FDA-approved immunotherapy, chemotherapy, and palliative options all remain available and can make a meaningful difference. You can visit mesothelioma.net to access more resources on treatment options for mesothelioma at every stage of the disease, or call us at 1-800-692-8608 or use the live chat feature on the website to work with one of our patient advocates right away. As for me, remember to post your questions below, and I'll see you next time.